Okay, I want to present a pathway, which is actually a clinical pathway transformation that we did for the Green Team, and it achieved the triple bottom line. So although it's very specific about HIV, the reason I think it's very important is that it's so translatable across so many areas of the NHS. So I'm just going to give you a bit of background. So we are a county-wide service, and Northamptonshire is a very long county. So we have two main towns, which are Northampton and Kettering, and then we have our patients travel from all sides of the county. So sometimes they could have up to a 50-mile journey to reach services, and that's actually really important. And then just looking back at HIV care, for those of you who are not familiar, so in the 1990s, we didn't have any antiretrovirals. So as HIV progressed in an individual, their immune system became severely compromised, and they got opportunist infections. And it was those opportunist infections that brought them into hospital. And they either lived or they didn't live. And those who lived went out again, and they came back 2 or 3 weeks later, either with the same opportunist infection, or they came back with a different one. And so we used to see people every 2 or 3 weeks, sometimes every 4 weeks. And it was a very brave person who organized to see somebody for a follow-up that was more than 1 month away. But that's obviously all changed. We now have excellent antiretroviral medications. We've got a background of really robust research, and so we know how to use them. And so eventually we started seeing people every 2 months, and we learned how to measure viral loads and resistance. And then we started seeing them every 3 months and eventually 4 months. And then by about 2006, people were still quite reluctantly starting to see patients every 6 months. And we haven't changed anything since then. The patients' lives have changed significantly. People with HIV can now have babies, they can have normal jobs, normal families. People are not expecting to die. And alongside that, staff, everything's changed in the NHS. You know, staff are stressed, they're more pushed for time, they're commissioning budgets, there's all sorts of complexities. So there are all sorts of reasons why we should look at this and other pathways. And of course, the reason we're all here is because of the increasing awareness of what the NHS does to the environment. Oh, sorry, I can't seem to move that slide on.
If you click on the slide, it will release it.
Oh, there we go. So some of this, thank you. This is about breaking habits and understanding what really hurts. So what really is hurting the patient about them coming up to see us, you know, every 6 months? And what is the fear about changing it? Because it's often not what we found through this project was it wasn't the patients who were worried about changing the pathway. It was very much about staff. And a lot of those staff were older staff. And I think some of their fear was about, well, you know, if you don't need me, then I'm not going to have a job, or they were just too overwhelmed to make changes. They didn't have time to think about it. So the question to everyone is, you know, are you worried about the environment, and are you worried enough to actually change behavior? Oh, sorry, now I need to go back. Okay, there we go. So we had learned during the pandemic that there were patients that it was too high risk to bring them into the service, because we were bringing them in for a blood test, but there was such bad COVID within the hospital that they were at high risk. So this was before vaccination. So we had to come up with a way of looking at each individual patient and saying, do they actually need this blood test, or actually can we just write another prescription? So we came up with a very sort of neat way of communicating with them, and a way of managing their pharmacy requirements and their pathology requirements. And what this allowed us to do was to divide our patients into 3 groups. So there were those who we considered to be very, very stable, which we called cohort A. And they were people who'd had a viral load that had been undetectable for quite a lot of years, sometimes way back to 2006 or before. And then there were those who fell into other groups. So they were pregnant, or they were new, or they weren't on antiretrovirals, or they had complications. And the plan for this pathway was to change it so that those who were very stable, and we clearly defined what that was, to reduce their attendance from 6 months to annual. And then obviously we put in a safety netting. So if a patient didn't want to do that and they felt unsafe, then they didn't have to do that. And we estimated that our cohort at the time was roughly 1,000 patients. And we estimated that about 70% of them were stable. and would be able to be offered this. And so it's actually turned out that it was much higher than that, but at the time we didn't know. And so we did all our figures based on 70% of our cohort. But to start it off, it goes back to that, who's scared of changing what? And so we started it off by not telling our staff what we were anticipating doing, but by asking our patients. So for the first 100 patients who came in, we asked them, how do you get here? Do you come by car? Is it diesel? Is it petrol? Do you come by bus? Do you bike, etc.? How much does it cost you to park? How many hours does it take from door to door? Do you have to take time off work? And we had lots of patients who were like on 0 hours contract. So if they came to see us, they weren't getting paid. And so there were lots of complexities around that. And then we also asked them, if we think that we could keep you safe, would you be happy or unhappy to sort of change to only have bloods once a year? And that was a key question. And then we asked, are you interested in the environment? So I'll show you those figures now. So this goes into the triple bottom line. So I've divided up to that. So the majority of people drove cars, and some came 140 miles, some came more than that. And that's because for HIV care, it's open access across the UK. You don't have to receive your HIV care in the county or the town that you live in. You can go anywhere you want. So if somebody really liked us and they'd moved out of the area, they could still come and see us. And we had somebody who traveled, hundreds of miles. And so the CO2 saved was equivalent to 108 return trips between Northampton and Glasgow. And for those of you who are not sure where Northampton is, it's about an hour outside of London. So this was a really long way. And that was the saving was per year, just by changing from a 6-monthly routine appointment to an annual one. And the consumables, so all the stuff that we used, the needles and the syringes and the PPE, etc., that costed out at £85,000 alone per year. But the big thing, which is not included in that 45,000, is it saved 350 hours of band 6 nursing time and 100 hours of medic time. Now we purposely did not cost that, though you can cost it. And we didn't cost it because we were worried that then somebody would take it out of our budget and say, oh, you don't need this. But actually we did need it, because if you go back to my second slide, which was about staff stresses and everything that's going on in the NHS, we've got increasing demand, we've got increasing complexity in our patients, we've got staff who are struggling to do their CPD, their mandatory training, and just have a breathing space. So saving this time has just been a godsend for them. And since we started rolling this out, there's a whole lot of an increased demand, because a lot of people are being brought in from overseas to fill social care gaps, and it's bringing a lot more HIV that we hadn't anticipated. So that was the environment and the financial. And the social, there was a 94% approval by the patients before they'd done this and before they knew anything about this project. That survey showed a 94% approval for reduced attendance. There was a 95% approval for an electronic link communication system rather than a letter. So we send an SMS to their phone. They then log into our system and they can see what letter we've written, so that there are no letters going to their houses, because many of them live in houses of multiple occupancy. On average, there was a £9.20 direct cost of saving for whatever petrol or what method they used of transport. And 84% of them said they were environmentally concerned. And when we looked at the 16 who said they weren't or hadn't answered the question, the majority they hadn't understood the link between the NHS and the environment, and many said we weren't sure why you were asking that. So we've rolled this out now, and we're doing a robust data collection system for later review. So let me rephrase that. We are rolling this out. Every time we see a patient who fits cohort A, we offer it to them. Only 2 people have declined this, and they have declined it they were both retired, and they said, well, actually, we really like coming to see you, and we live just around the corner, and it's the one thing that we like to do. So they've had an option, they can carry on. It's been environmentally, socially, and financially hugely beneficial, with significant change to the pressure on the staff, and I cannot emphasize that enough. But I think the key thing about this is we did this for over a cohort of 1,000 patients. There are over 100,000 HIV patients registered within the UK. And yet our national guidelines still recommend a 6-month and a 6-month routine regular review. I mean, my opinion is it's absolutely not necessary. But I think this applies to multiple other specialties and particularly outpatient services within the UK. So I just want to thank all the patients who have been a part of this, and obviously to Rachel and her team for flagging it up and for giving us the opportunity to do the study. And in Northamptonshire, the study and the Green Awards were supported by the Northamptonshire Health Charity. So I'd just like to thank them. Thanks very much.